We are going to go see a surgeon because I found out about 2 weeks ago that I have basal cell cancer right here. This mark on my face, it's been a part of me for more than 2 years now, and I let that go on way too long. So we're going to go in, as is described to me by the doctor, we're going to go in and he's going to find out how deep this thing is. And it's called Mohs surgery, and very common. It's about awareness and protection. I, like many other people of my generation, I confess, I used baby oil and not sunblock. I used Sun-In on my hair, maybe some aluminum foil, just silly. Honestly, I did not sleep much last night, but then I am a little bit nervous. I'm a little bit nervous about the procedure, but I know I'm in great hands.
Mike Swan, very nice to meet you.
Melanie Chapman.
Appreciate having you guys. You up for this today?
I am, absolutely. Yeah. I was nervous, but excited to get it done.
Kind of pearly hue in the skin, and that's really what we're after. And I'm marking the outer border of what's obvious cancer. Roots could be bigger. You know, if they particularly, and then I put a couple lines on here that will kind of help me, once the tissue's off, to determine where 12 o'clock is, and 6 and 3 and 9, so that if I find roots that extend beyond the initial margin that I've marked of obvious tumor, then we'll know exactly where they are. And that's really the deal with Mohs that's different than traditional excision is I'm not taking a margin around this, any extra, but I'm gonna look at every cell on that outer perimeter.
You're going to get a little poke, sting, and burn, okay?
Okay. So worst part of it right here. Okay.
1, 2, 3.
Okay.
I'll tell you what I'm going to do first is I'm going to use a kind of, I would say it's like a ice cream scooper, a really dull curette. It's real small. Okay. And I'm going to kind of just rough up the top edge, and it will really show me kind of where the roots really are. Sometimes they're a little bit bigger, sometimes they're not. All right. And it'll kind of help me with depth a little bit. And then I'll make the first, do the first Mohs take. So, you know, the numbing doesn't really get rid of scratch, and you can feel pressure and stuff like that. Okay. So I'm just kind of lightly scratching on the top here. And
I can't feel a thing.
Good. Yeah, and I think it's marked pretty appropriately. I've got this in a petri dish here. I'm going to come over here to the map, and I'm going to mark my edges. What we did under the microscope. So you probably have about 40 minutes, okay? And you'll be the second to know right after I read these slides. So it takes, we take the tissue to the lab, and it takes a little bit of time to freeze the tissue and section it to where we can kind of do that procedure where we look at all of the edge. And Kim, our amazing histotech, is in here to take this from tissue through the cryostat, the stainer, put it on slides, and then I'll read the slides over the microscope over here.
That was a question I was going to ask of Dr. Swan about why this area by the eye seems to be so common, even with my general manager, my friend. Mm-hmm.
I'll tell you, I have an opinion, but it's not based on a lot of science, just a lot of cases, is that people that wear glasses get magnification of the sun here. Yeah, so your tissue is chilling right here. We've got it mapped and inked, and Kim's already sectioned it. She bisected it. So the inked edge is what that we see here. Maybe let's look at the left one. You get blue and then red, and then that outer edge is the skin edge. Okay. So you can imagine the process is kind of unlike a loaf of bread. It's like an orange, say, that's a good way to say it, that's cut in half. And we're going to look at all of the orange peel.
Okay.
Okay, so the inside we know is basal cell, so we're going to really focus on only getting it clear.
Okay, good analogy.
Separates this from excision. So. Even sunglasses that are reflective, and so you actually get more rays here than you would on the upper eyelid above because you're getting double. And particularly people I see that wear frameless glasses, get them a little lower, kind of on that prism effect on the side. Yeah, so we do see a lot kind of. Do you wear glasses?
Yeah, readers oftentimes will put contacts in today for this, but and that's what a lot of people thought too, is just some irritation from my glasses.
So this is these are Melanie's slides, and basically we're going to check all the outer edges and make sure that we've gotten everything. See if there are any roots that are kind of piercing through. So I'm tracking along the ink margin, so I know that the ink on my map, the blue and the red, correspond with the ink that is on the tissue that we inked when we took it. And she does have some roots that are positive. You know, the tumor was in the middle of this, and then we've just gotten the couple of roots that are piercing out through the edges of what we took. And so we'll have to take a little bit more on this edge here, and we'll take a little bit wider, just a little bit than what we see, in case those roots come out and around. And the same on this side, we'll take a lot of this lower edge laterally. You have a couple spots that are positive. This over-represents the amount of roots, okay, by the size of the marker, basically. Okay. The roots are very small, but they're in these areas, and I will take tissue to about where the areas are, okay? I'm gonna do it in two little, basically, pieces, and we're really under it, okay? It's just, we need to be a little bit wider, so it's not terribly deep, and so that just helps me. This actually seems high, but I'm going to take it on that medial side just a little bit more. When we spread the eye out, it looks a lot bigger than it really is.
This may sound silly, but because it is cancer, it does have roots.
Okay, so I'm going to take this to the lab, and I'll see you in about, I'm thinking this will be a little quicker. It's less tissue. Okay. And probably 30 minutes or so. Okay. And I should have hopefully a clear margin, and then we'll talk about how to close it, okay? Explain it as, you know, scars, when they're ugly, they look like a ditch. Mm-hmm. And the contractile force of the scar pulls everything down to it. And so what I've done is I've built up with tissue tension with these deep stitches. I've kind of everted that so that it sits up really high. And as those stitches dissolve slowly, it will flatten out and be a little fine line.
Oh, okay, that makes sense.
Yeah,
okay.
So that's how you can kind of hide it really well.
I'm all for beautiful.
Yeah, you're a little swollen and puffy and stuff like that, but I think it's going to heal really nice.
Oh, so cool.
Yeah, you did great.
Did it.
Yeah, so I'm really happy. I honestly, your first layer being positive, you know, we just never know if they're going to go 2 layers, 3 layers, 4 layers, and then they could be sometimes twice as big as what we expect. And that's hard on us, but it's really hard on the patient because you're here a long time, and then your reconstruction gets really big. And I think we were probably a millimeter away or so from this being a graft. You're going to do great. You let me know if you have any issues.
Awesome. Thank you for your help.